Hello everyone, I am Professor Camran Nezhat, and I'd like to thank all of you one by one for joining me, all the viewers around the world. Also, I would like to thank specifically my patients from everywhere that less than a year ago encouraged me to start and join TikTok and Instagram for the purpose of sharing my experience about endometriosis with the community at large. So it is all thanks to you and your interest that I am doing this. There are many people behind this that helped me and organized this for me. On the top of it is worldwide EndoMarch, EndoMarch, that its goal is to raise awareness about endometriosis and help all the patients around the world that they have endometriosis. In worldwide EndoMarch, people like Barbara Page, Zoe Pennington, Marianne Smith, Melanie Salem, Leslie, Ashley, Katie, all the nurses, Shruti, Sandy, Wendy, and Nisi, and Taylor. There are so many in the surgery, in the OR, that regularly try to find interesting topics for you. So I may forget some of them, but I like to thank all of them that are behind these efforts to try to educate community at large about the enigma of the endometriosis and what endometriosis is capable of doing. I do encourage you and I thank you again for your interest. A lot of my patients that they come and some of them they say, well, this is of interest. For example, one of my patients less than 3 weeks ago that she had lost one of her kidneys to endometriosis, and her daughter asked her mother that please make a TikTok on that. And because of the encouragement of that patient of mine and her daughter, we made a TikTok and Instagram on silent loss of the kidney due to endometriosis, and it has had more than 200,000 views. And due to the interest of another patient of mine about endometriosis and pain, we had, and that it was associated with significant pain at the time of menstruation with the bottom pain, rectal pain, and back pain. We had another TikTok that had more than 2.4 million views, and many of you have watched and have asked questions. So it is all thanks goes to you, to the viewers, and again, my patients and worldwide EndoMarch, and those of you who would like to help us put an end to the enigma of endometriosis and help all the patients with endometriosis, their families, and their society in general with endometriosis. Endometriosis is unfortunately a very perplexing disease. And what I try to do in the next hour to try to answer thousands of questions that came to the TikTok when we had those viewers that there were several 100,000, and also one of them more than 2 million. So we have tried to download those questions and try to answer them as much as possible for you. I encourage you that you please send us all of your questions again, and I will try to address it for you as much as possible. So, in summary, endometriosis is a disease that affects practically patients that the majority are XX when they are born as an XX patient. Means they are born as genetically as female patient, XX. And it could affect the patients from all ages. It is most common on patients between the ages of the menarche and menopause, but it doesn't mean it stops there. It could affect patients that are before menstruation, teenagers that they haven't started their period may be affected with endometriosis, and women or patients who have gone to menopause. Even after menopause, they could have endometriosis. However, the incidence of the disease is far more common in the ages of 14 to 55, around the ages of menopause. Endometriosis is very depending a lot on estrogen. Estrogen is a hormone that mostly is produced by the ovaries. And ovaries, although estrogen can be produced by other organs like the adrenal gland, or the body fat also can produce estrogen, but the majority of the estrogen comes from the ovaries. And estrogen to endometriosis is like water to the grass. If you give water to the grass, grass grows. If you stop giving the water to the grass dies. So the more the estrogen, the chance of the endometriosis growing is more and more. But it doesn't stop there. As I mentioned, endometriosis is very enigmatic. Sometimes produces its own estrogen and grows even after menopause. In some patients, endometriosis, it is self-limiting, means after a while it stops progressing and dies down by itself. So there are many issues that could be addressed, and I have addressed and I have written a lot about this subject on different papers over the years that you simply can download many of these papers for free by looking or putting my name, Camran Nezhat, C-A-M-R-A-N, Nezhat is N-E-Z-H-A-T, and search the literature, Google search it, or medical search it for the articles interesting that you are looking for to address your question. But endometriosis in general, it is a disease that could affect all of the body. It doesn't affect only the reproductive organs. The reproductive organs are the uterus, tubes, and the ovaries. The disease is not limited, doesn't limit itself only to these organs. It could affect practically every organ in the body, and it is a whole body disease. And when that tissue, that it is extra tissue which grows in these organs, it could create problems by causing inflammation. For example, when the tissue that usually is inside of the tissue which usually it sits an area that there are no nerves, it may cause no pain at all. But it is just like a piece of sand in the eyes or a rock in the shoe. If the piece of sand, excuse me, or the rock is inside of your pocket, it doesn't cause any problem. But if that sand is inside of your eyes or a big rock in your shoe, it could cause a lot of discomfort. That is exactly what happens when patients with endometriosis have a lot of pain. That endometrial tissue, that excessive tissue, it goes and sits around the nerves, for example, in the back, and causes back pain. If that excessive tissue sits on the nerves around the rectum, it could, during the menstruation especially, or during ovulation, and specifically at the originally, or it could cause a lot of inflammation and cause a lot of rectal pain, butt pain, and during the menstruation causes diarrhea or sometimes constipation. The same excessive tissue, if it is sitting around the lungs or the diaphragm, with the menstruation, the patient may end up having shoulder pains, and this is more common on the right side. Usually it is right shoulder. So it could cause a right shoulder pain, and sometimes even could cause shortness of breath, and occasionally when endometriosis sits on the diaphragm, it penetrates all the way towards the lungs. It could sit and cause problem with coughing up blood, and sometimes it could cause some collapse of the lungs, endometriosis. So, but usually this is much more less common, a lot significantly less common than disorders of the reproductive organs. So endometriosis of the diaphragm, or endometriosis of the kidneys, or endometriosis of the lungs are, although possible, but usually they are less common. More common is when endometriosis affects the diseases of the pelvis. And what is that? Ovaries, tubes, uterus, the bowel in the back of the uterus, bladder on the top of the uterus, and the nerves around the tubes and ovaries. So this could also cause significant inflammation. The inflammation is usually the problem of almost all the diseases. When they cause inflammation, create problem. In case of endometriosis, the inflammation could cause pain and infertility. What it does, the endometriosis could cause significant inflammation, and in cases of patients who want to have children, it could cause miscarriage, a gamut of all the problems. First of all, it might cause you not to get pregnant at all. Even if you have a lot of IVF, still it may prevent you from getting pregnant. It may cause problem for the embryos, prevent them to implant in the uterus. It may cause problem, the toxicity, the hormones produce, the toxins produced, the poison produced by endometriosis. Those hormones could kill the sperm and the egg and the embryo, and also prevent implantation. And also sometimes prevents the sperm and the egg to get together, to join. So there are a variety of different reasons that endometriosis could cause patient not to get pregnant. Now the interesting part is that endometriosis doesn't always cause infertility at all. It doesn't. There are many patients who get pregnant, have children, and they have no pain at all. They have endometriosis, and endometriosis grows and grows, and sometimes later in their life manifests itself by other problems. I brought you an example that recently a patient of mine already has a child, and she already has lost a kidney because of endometriosis, and she didn't have even symptoms. Even her urologist, by coincidence, they didn't know what it was, because all of her ultrasound, MRI, all the images were completely normal. The urologist says, I don't know why you have lost your kidney. And that patient was quite intelligent, herself searched the literature, and she found one of our articles that it talks about silent loss of the kidney due to endometriosis. And she sought our care, and we evaluated her, and because she has already posted on TikTok and also posted on Instagram, I let her comment herself further about her situation. But endometriosis in general, doesn't necessarily always cause pain and doesn't cause always infertility. But pain and infertility are usually the most common presenting symptoms. So that makes it for educated audience like you, that you are interested to take care of yourself in case of infertility. If you may have no symptoms at all, all of your tests are completely normal. All of your tests are completely normal. And also your partner tests are completely normal. And you are not getting pregnant, and they call you are unexplained infertility. Most probably, in our experience and according to our findings, you have endometriosis. And if you are younger, But I mean, you are in late 20s and early 30s, if you are treated properly by a very experienced endometriosis specialist who very thoroughly evaluates you and knows how endometriosis really looks like and treats you surgically by removing your endometriosis properly without causing any harm, your chance of getting pregnant, according to our data, are excellent, and in younger patients are even better than IVF, according to our data. Now, if you are older, and also if you have had IVF, and IVF, a lot of times, a lot of IVF doctors bypass surgery and go ahead and directly go to IVF. And that is one way to do it. And that is no problem at all. Because surgery by itself, there are not enough surgeons around the world that they are able to thoroughly treat the patients without causing any harm. So IVF, it could be done, and it could bypass that process if you want to get pregnant and you go through IVF. But if you do not get pregnant with IVF, again, and you have practically no symptoms at all, it is not the end. That is another area for you to look into it according to our research and according to our experience that we have also again published it. Patients who have had failed IVF and failed therapies still could significantly benefit if they are treated surgically and have their endometriosis thoroughly treated by a very experienced surgeon. It is very important that when the surgeon treats endometriosis, be not too aggressive and be very cautious around the ovaries, and also especially if endometriosis involves the rectum, around the rectum, in the back, between the uterus and between the bowel. In some areas, some surgeons, especially I have seen it in some foreign countries, not United States, I have seen it unfortunately in some areas, they go and do too many bowel resections. That is totally unnecessary in the patients who are trying to get pregnant. And also, again, we have published about it in very important medical journals like American Journal of OBGYN, and also in the Journal of Nature Urology, and also in a Journal of Obstetrics and Gynecology, that are very important journals in the United States and around the world, and also in the Journal of Fertility and Sterility, in the Journal of Society of Laparoscopic and Robotic Surgeons. These are all papers that we have published and other journals that how to deal with the patients that they are trying to get pregnant and they have endometriosis, and we should be very conservative, be cautious not to do unnecessary and too aggressive surgeries on the ovaries and on the bowel, because it could be more damaging. But if it is done properly, selectively in the proper way, the chance of success is excellent. So in fertility patients, I have good news for them. They should, especially around the holiday season, that they do not need to be depressed. They should be properly, there is a lot could be done for them, especially if the IVF has failed. And there are many, many excellent infertility specialists that are familiar with excellent endometriosis surgeons, that they are able to refer them, to treat them, and their chance of success is excellent. So this is related to infertility, that it doesn't have, that patient has no pain at all the tests are normal, everything has failed, and she has not gotten pregnant, and there is hope for them. That is one. The other issue is the pain of the different organs. If you have really severe pain around the time of menstruation in your back, it could be related to endometriosis. If you have pain radiating to your legs and it is getting worse during your menstruation or ovulation, this could be endometriosis. I have had patients that over the years, and I saw one of them yesterday, Friday, that this patient, for years, all of her pains had been contributed to irritable bowel syndrome. All of her tests are normal. CT, MRI, ultrasound, everything. But her pain gets worse and worse around the time of menstruation. Many of these patients, they have rectal pain, sometimes diarrhea, sometimes constipation, and some patients even have some urinary symptoms. So, not always, but many of these patients have endometriosis. In some cases, could be related to other disorders. Some of them, they might have problems with really irritable bowel syndrome too, but very often MRI, ultrasound, CT may not show the disease. Although in some recent years, some of the ultrasonographers and some of the radiologists are able to diagnose endometriosis better. But when MRI or ultrasound or CT diagnose endometriosis, usually endometriosis is very far in advance. It is more severe. So they are able to see the pockets of endometriosis or fluids between the uterus and the bowel or between the uterus and the bladder and diagnose endometriosis when it has gone too far. But if it is very early, they cannot diagnose it, and the pain, unfortunately, very often these patients go from doctor to the doctor, all the tests are normal, and they tell them it is okay. And sometimes, again, unfortunately, the patient thinks the pain is in her head, is a product of her imagination. In some occasions that I have seen and I see, unfortunately, some physicians that they mean it very, very well. They have good intentions, but unfortunately, it is not their finest moment. They misdiagnose endometriosis and they think the patient is depressed or they think it is psychological and they give the patient antidepressant. When I have seen it over and over and over, quite educated patient has no problem, no reason to be depressed, but has pain, and when you laparoscope this patient, when I am looking inside, she had endometriosis around her back, on her nerves, around her rectum, sometimes around the bladder, and on the diaphragm, but there are like small little lesions that they are not big enough to be able to be picked up by ultrasound or CT or MRI. And they are sitting on the nerves and they cause the problem. The same is for infertility patient. It is not visible, but it is sitting on the ovaries, around the fallopian tube, around the pelvic side wall, and causes the toxins that causes problem with infertility, causes the pain, sits on the nerve, and causes the problem. So that is the issue. And that is exactly the issue how, unfortunately, when endometriosis is sitting on very sensitive organs, that there are not a lot of nerves, and I'm specifically referring to the ureter. The ureter is the tube which connects the kidney to the bladder. And there were many questions about this area. That is one area that the attention of the patient is very important. Many of you had questions. How should you think if or be aware that endometriosis could be around your ureter, leading to your kidney loss? First of all, let me tell you, thank goodness, this is not very common. It happens very, very uncommonly, but unfortunately it does happen. So if you have pain every month, mostly in your back, around your kidneys, in your back, and mainly, usually it is only one side, around your, in the back pain, in the middle of the abdomen, and it gets worse around the time of your menstruation or ovulation, and then completely disappears, that could be endometriosis sitting on your ureter. Gradually, unfortunately, that pain could becomes more prominent. As the endometriosis invades and surrounds the ureter more and more, the pain gradually gets a little more, and when the endometriosis completely chokes the ureter closes up, and kidney gradually, unfortunately, dies. Thank goodness this is very uncommon. So if you have only flank pain in one side very often with menstruation, it is a good idea that you see your doctor who is a specialist, see a urologist, go and see an endometriosis specialist, that they are familiar and they can order an ultrasound for you to check your kidneys and your ureters. Very simple, an original evaluation. You should see your physician, number one. I'm giving these recommendations as a general recommendation. I don't give it specifically for any, because I don't know people, but they had many questions. Every patient needs to be examined by a physician before ordering, but in general, an ultrasound or CT or MRI of the kidneys and the ureters with contrast could diagnose endometriosis of the ureter. I want to tell you again, it is not very common, but if anybody wants to be evaluated, you see your physician, they could order an ultrasound of your kidneys, your ureters. Unfortunately, at the present time, there are not any specific blood test for endometriosis. There are some tests available that they can help you to see if there are evidence of inflammation, that it is endometriosis is also an inflammatory disease. And we have published about one of them. It is called BCL6. And I do want to let you know I have no relationship with the producers of the BCL6. I don't have any relationship, but I do know that is a good test. Many of the physicians do, especially many of the infertility specialists that I am very familiar, they do this test to see if there is any evidence of inflammation for endometriosis. That could be a guideline. There are some other tests but they are not specific, and unfortunately sometimes could be misleading, like CA125. It is available, and a combination of other tests. We call it OVA1, if there are large cysts on the ovaries, large chocolate cysts on endometriosis. These are some tests that could be evaluated, but unfortunately they are not specific. Also, if you are worried about it, there is an app that we developed, that app, and we donated that app to the EndoMarch. It is completely free. It is called Nezhat, my name Nezhat, Nezhat Endometriosis Advisor, and that is a completely free test, and it is donated to EndoMarch, and it is a free test. You can take it, and if you think if it became very positive, more than 90% or even 75%, definitely go and see your physician who is familiar, and he or she could further evaluate you and help you. So these are the problems with endometriosis, that there is no specific test. The good news is that many researchers around the world are doing significant work to find good tests and find ways to diagnose endometriosis, and the future is bright. We are making significant progress in this area. There are there are some other tests called, for example, endometrial function test. Endometrial function test is another test that some of your physicians might do it, help you, and perform it for you. That it is another clue that could help you, because you don't have to have diagnostic laparoscopy, because right now the only way to diagnose endometriosis 100% is by laparoscopy, that you remove the tissue and send it to the pathologist. And the problem is that, unfortunately, there are many physicians who do laparoscopy and claim to be endometriosis specialists, but some of them do not recognize different variations of endometriosis. That is another dilemma. And I train every year some of the most smartest doctors from around the country that they have been trained in the United States in the best programs. They come and they are my fellows. They spend 1 or 2 years with me in our program to learn about endometriosis, and when they come, very often they don't even know different shapes and forms of endometriosis, and that means their teachers don't know. That means their teachers don't know what to teach them. So that is the problem. That is the problem with the endometriosis that are so vast. That is why fundamentally we need many, many aspects of teaching, education about endometriosis. The teachers don't know how endometriosis often looks like to teach it. So we need many, many changes, teachers in the level of the teachers, research, etc. Again, the good news is that we are doing significant progress since Worldwide EndoMarch 10 years ago started, and we have been advocating a lot of awareness about this. Many other organizations around the world raising awareness, and research is being done. I am familiar myself with several physicians with significant. We are doing a lot of research ourselves with Dr. Linda Judice at University of California, San Francisco. A lot of tissue sampling, many of my patients, and I thank every single one of them for participating in this research. We are doing some of this research with, I'm very happy at Stanford, also Dr. David Stevenson, who is a good friend and colleague of mine, one of the past deans. He has very significant interest in endometriosis. He has gotten involved, and I congratulate him that they are trying to really move the pendulum forward. I know Dr. Bullenberger in Northwestern, Sardar Bullen, is interested and doing a lot of work in this area. Dr. Mismer and Dr. Vanderan in Oxford and Misma, they are all interested. Dr. Hugh Taylor in Yale. There are many areas of interest in endometriosis. Our colleagues and friends in France, they are doing significant work. They are trying to do work with saliva test for endometriosis. So the interest, it is far and everywhere, that I am sure sooner or later we will have a good diagnostic test for endometriosis. There are some other colleagues of ours, Peter Dotino and his groups in New York City, in collaboration with my brother Dr. Camran Nezhat and Dr. Sina Nejad, they are trying to do more work to diagnose endometriosis, and other groups, the inventors of OVA1, they are trying to specifically try to do work for endometriosis. So there is, when we have a better way to diagnose endometriosis, then hopefully we will be able to treat and predict people who have no symptoms at all and they have endometriosis, and then we hopefully help them to to prevent it first, hopefully, and second, if we know if they have it, we try to help them to stop it from the progression. There were many, many questions that they were asking. Should everybody have a laparoscopy? No, absolutely not. If you have a lot of symptoms, for example, you took the app, Nezhat Endometriosis Advisor app, and you saw your doctor, and there is a risk, and you are a teenager, you are a young woman, you have, your ultrasound is negative, all of your tests are negative, and there is a high possibility of your endometriosis, of course, there is no need right away to have surgery. Many times, simple hormones like birth control pills, I understand that it is not good for everybody, but a lot of times, birth control pills, it is, in my opinion, birth control pill is better than having surgery if there is a way. You can use birth control pills and your doctor and after examination, prescribe for you the lowest dosage possible hormones of the birth control pills for a long time. It will help and stop the progression of endometriosis. Endometriosis is a progressive disease. As time goes on, unfortunately, it gets worse and worse. Not always, as I said, endometriosis is a very strange disease. I call it great masquerader. Anything you say with endometriosis, I have seen it happen. So, but if you are a young teenage patient and you have all these symptoms of pain, discomfort, all of your tests are negative, your physician has seen you, there is nothing wrong with taking lowest dosage birth control pill, and hopefully under your observation of your doctor, the majority of the patient are helped. If you have done all of that, and unfortunately after a while birth control pill, in our experience we have noticed after a while it stops working, then you see a proper physician who is very experienced, evaluates you, your pain is not in your head, they can do a laparoscopy and properly treat your endometriosis, and your prognosis is going to be excellent. The same way, if you are an infertility patient, you have tried everything else, you have not gotten pregnant, and still you want to have a child, all of your tests are normal, and nobody is available to help you with a proper, there are not enough endometriosis experts, unfortunately, around the world who can treat all the patients with the least possible side effects. Because they are not, and you don't have access to the surgeon, then talk to your doctor, might find you the lowest dosage of hormones, birth control pills, and other hormones that the doctor, they are very familiar, that they think might help you. They may help you to help get pregnant. It is possible. Don't give up. There is hope. It is not in your head. It is not part of your imagination. If you are not getting pregnant, I have seen, unfortunately, sometimes patients who have come to me, and I see them regularly. I see patients regularly who try to get pregnant. That is mainly what my practice is, that patients who have tried to get pregnant and they have not gotten pregnant, they have tried everything else, and they think it is their fault. They think they are being punished. Absolutely not correct. Occasionally they might have had earlier in their life a miscarriage or an abortion. They think they are being punished. That is not correct at all. If you are not getting pregnant, you didn't do anything wrong. If all of your tests are normal and your partner tests are normal and you are not getting pregnant, everything you have tried, it is not your fault. You have done nothing wrong. And I say that because I see some patients that they blame themselves. Please do not. This is very often the problem is endometriosis, and the blame is on endometriosis. And shame on endometriosis and nothing else. And we can manage it. So these are the conditions. But there are not enough experts around the world. Some of them, again, low dosage hormones of very harmless hormones like birth control pills or progesterone, a lot of time help this patient. So these are areas that not necessarily everybody has to have surgery, but a lot of times hormones helps, and low dosage birth control pill, other hormones helps. If it didn't help, still there is hope. Surgery is an option by a very, very experienced surgeon. If the surgeon is very experienced, in our experience, surgery is better than any kind of hormones. Because by surgery and excision, we remove the whole disease. We remove the whole disease completely. it is like we are going and remove that weed, that plant, endometriosis, like a little plant, like a little tree. If you know, like weeds in the back here in my yard. If there is no water, here I live in California, and we are lucky right now. I am very happy we have a lot of rain, because we haven't had rain for several years, and there has had a drought. So I am very excited to tell you right now we have rain, and you see those trees are happy, those grass is happy, because the rain comes in. But if the rain here in the summer, we don't have rain, all this grass becomes completely yellow. When the rain comes in, the grass grows again. Endometriosis is exactly like that. So for us, the best treatment for endometriosis is to go by surgery and excise it and remove it, especially for infertility patients. When I go and remove the endometriosis, and completely the chance of success has been amazingly great. I work with some of the best infertility specialists in the Northern California. I am very lucky. Examples are Dr. Kelly Bake in Los Angeles, Dr. Evazadeh, Dr. Sally Tazuki, Dr. Sunny June, Dr. Lane, Dr. Court, Dr. Moran, all are in Northern California, Dr. Purcell. These are all physicians that I work, and many other physicians. There are infertility specialists that they do a great job for the infertility patient. They don't get pregnant after failed IVF, a group of them. I do surgery, I treat the endometriosis very thoroughly, and the chance of success is great. So surgery and excision is the best treatment, and the majority of these patients that I treat them, the endometriosis, the recurrence rate is very, very minimal, and if it is done. The recurrence rate, many other questions they ask, how is the endometriosis, how is the recurrence? Endometriosis is very enigmatic. The recurrence rate varies. It is not one size fits all. It depends where you live, what you eat. Hopefully you are not living in an area that the environmental hazards are high. The more environmental hazards, unfortunately, the risk more. If you live around where there are toxins more, chemicals more, unfortunately, the risk is higher. The healthier the diet, and in my website there is a diet for endometriosis. You can look at nezhat.org, nezhat.org. There is a diet there. You can look for it. And a good diet is helpful. The more hormones you receive, unfortunately, infertility treatments, patients that they have to go through IVF, patients that they are going through IVF and receiving a lot of hormones to produce a lot of eggs, the production, the more eggs you produce, the more estrogen, the more risk of endometriosis coming back. Just like the grass in the back with the rain, endometriosis, the estrogen is like the rain. It makes the endometriosis to come back more. So for those patients that they are undergoing infertility treatments, the amount of hormones they receive should be limited for production of the eggs. The more ovarian hyperstimulation to produce more eggs, the more estrogen and the more risk of endometriosis. Endometriosis could progress. I have had patients who come to me, they said they didn't have pain for years and years. Then they started having IVF. Gradually, as more IVF they had, more hormones they receive to produce more eggs. They had pain with their bowel movement gradually. They had pain, diarrhea more with their bowel movement, and more pain with their menstruation. And sometimes I had a patient who came to me specifically because her pain in her shoulder gradually got worse. And she had endometriosis on her diaphragm, and of course endometriosis around her tubes and ovaries too. And I have had some of those examples on TikTok and also on Instagram to demonstrate. Unfortunately, sometimes with social media, you try to help the patient, the information comes across wrong. So I see you have had a lot of questions you are sending me, and those questions, I try to answer some of them, but I promise you, I would ask my assistant to help me. We find all these questions, and I would bring it up to in future sessions to answer this question. I am trying to answer the past questions in the past, and today I didn't explain anything, but right now one of them is asking me, can you explain DIE, die, capital D, capital I, capital E means deep infiltrative endometriosis. In deep infiltrative endometriosis or DIE, endometriosis unfortunately could gradually, as time goes on, becomes very fibrotic. And many patients, unfortunately, over the years, don't receive enough help. As I said, sometimes endometriosis has no symptoms at all, nothing. As I brought you the example of the sand in the eye or the rock in the shoe. If the sand is not in the eye or rock is not in the shoe and it is in your pocket, it stays there and gradually puts pressure on the pocket and heavy and cause a hole in your pocket. The same thing seeing here in infiltrative endometriosis sitting between your uterus, for example, and your rectum or any other areas of the body. Sometimes there are no nerves, and the pain threshold on different patients are also different. The pain thresholds in different patients are different. So some patients, they think it is normal to have that pain with menstruation, and they don't complain. And many patients, they think everybody has that pain. So this endometriosis stays there, bleeds every month, and gets worse and worse and worse, and becomes fibrotic and infiltrates, goes towards the other organs. For example, between the rectum and the uterus, it keeps going towards the vagina, keeps going towards the vagina, and sometimes goes all the way, even inside of the vagina. Sometimes keeps going and infiltrates towards the nerves, towards the back. Sometimes keeps going and infiltrates towards the bowel in the rectum. And sometimes the same deep infiltrative endometriosis keeps going, goes towards the lungs, goes to the chest. And occasionally the same deep infiltrative endometriosis keeps penetrating and goes towards, for example, the bladder, or as I mentioned before, towards the ureter. And that is the ureter, usually, unfortunately, when it keeps going down, very severe, causes silent loss of the kidney that we posted recently again, thanks to the encouragement of the daughter of a patient of mine, that she wanted to put it, and I accepted, and I put it for her, and she is on herself. She has been very kind, and she has responded to a lot of you, and also she has also posted. The issue of the endometriosis, that is deep infiltrative endometriosis. If you need more question about it, I know that is the only question that I saw here, and today I answered it. I promise you I would ask my help again to assistant to help me to figure out this question on TikTok, and I would come back again in the future. The reason that I decided to do TikTok, it seems TikTok more audience reaches on TikTok. On Instagram, we put the same thing, and unfortunately, after 24 hours, they stop promoting it. And I do want to let you know, unfortunately, Instagram requests to pay money for more, and I don't want to. We do not want to accept any company to come and sponsor it. Some companies have come to me and they want to sponsor and they want to promote our. We have not accepted any money from any company, and we do this for the purpose of education to help the patient. We are not affiliated. Many companies who have come to us, they have offered to pay money to advertise and promote our sites. We have not accepted any of them. Our intention is to help you as patient, to show you. That is my only intention. My only intention is to help the patient with endometriosis around the world to find a cure for them, to a method to diagnose them, and hopefully to prevent them. So as I wanted to do it only for an hour, and you have had many, many questions, and I try to only answer the deep infiltrative endometriosis. I answered that one. In the future, I would come back again. I thank all of you for your interest. I am going to tell my assistant, Zoe, to this tape. She told me we can, it is being, TikTok keeps it, and we can put it on again. And also in the future, I will come and answer all of your questions. I wish every single one of you around the world the most wonderful and happiest holiday coming, and the most prosperous years for all of you. Stay healthy. We will conquer endometriosis. Help is there. Do not let it get you down, endometriosis. And all of us, forward we go, and good luck to everybody. I wish you the best. Bye-bye.